who met on a regular basis. And there's some pretty consistent patterns of care across all of these units, with a systematic approach to assessing people, a systematic approach to just the basic management, the way they manage the fluids and swallowing and feeding, the way they manage early mobilisation, having nurses who are really skilled in stroke care, and then that merging in with a very classic multidisciplinary rehabilitation process and discharge planning. And so most of these units it wasn't rocket science, it wasn't high-tech medicine, but it was doing the simple things well and doing that consistently. And if you look at all the data from across all the studies, you can present them in this way. This is what I've got here in the left-hand column is the categories of outcome at about 6 to 12 months post-stroke. And as you can see, they're very basic categories, but and you can work out the sort of proportions in those who were allocated stroke unit care, those who were allocated general ward care. And you can see that for every 100 people managed in the stroke unit, there were maybe 3 or 4 extra survivors, and there were a couple who would avoid long-term nursing care. And that translated into about 5 extra independent survivors. Oh, there it is. Sorry, my screen's much faster than yours. I'll try and remember to delay. And these services appear to be cost neutral if you've already got the staff in place. It's essentially an organisational issue. In some settings you maybe have to invest in staff to get up to a basic staffing level. But basically these aren't expensive hospital services in most developed countries. And this impact may look quite small, but you'll come to see it in a few minutes. It's actually one of the most important probably the most important intervention we have available for managing stroke. One of the criticisms that came from people looking at these studies is, well, that's all very well, that's very motivated research settings where they've got good resources. How do you know it works in routine practice? And in fact, there have now been a fairly large number of observational studies. So these aren't clinical trials, these are studies that have taken observed normal services, warts and all, and they've done a statistical analysis of what predicts a good outcome for a stroke patient. And of course there's all the things like stroke severity, age, but across all of these studies, one of the consistent prognostic features was that whether you were managed in a stroke unit or not. And this graph, you don't need to worry about the details, but each red dot is an individual study, and it's looking at the chances of a stroke patient dying during the first year after the stroke, and comparing those managed in a hospital with a stroke unit versus those who were not. And anything to the left of the solid line suggests that there are fewer deaths in the stroke unit group. And you can see over all these studies was pretty much consistently lower chance of dying if you were in a hospital or in a stroke unit. And these studies now come from literally all over the developed world, It's quite a lot from Scandinavia, one or two from the UK, Canada, and there's been work done in Australia as well. Dominic Cadillac and people at over in Melbourne. And so that there's pretty compelling information to say that this is an intervention that can work in our normal services. So that's maybe a bit of old hat, but it gives you, if you like, the basis for the arguments why we should be having stroke units for a long time. The next step in the chain I'd like to look at is what's been termed early supported discharge. Now this is a service model that's probably appropriate for a large minority of stroke patients, maybe about 1/3. And the reason is that a proportion of stroke patients will make a very good, quick recovery, and a proportion will have very complex needs requiring quite prolonged hospital care. But early supported discharge is really designed for that middle group. And these are really services that challenge the conventional way of providing rehabilitation and said, should we not be trying to get people home more quickly and provide rehabilitation in the home setting? And I can just sort of illustrate that in a, there we go, illustrate that in a sort of little diagram. In the many services, the normal patient pathway is come into hospital, get some acute care, some rehabilitation, and actually they kind of fall out the back door, and people often report they feel they've been abandoned, that they have maybe some continuing support but no continuing rehabilitation. And what the early supported discharge concept did was say, well, can't we move the discharge point a bit sooner but not withdraw rehabilitation, provide it in the home setting? And they look to achieve that through having a supported discharge team, which is usually built around physio, OT and nursing. It's usually a combination of those professions with a bit of medical input, some social work input, some speech and language therapy input. And so that was, if you like, was the concept. And people did things slightly differently in different settings, but there are actually quite a large number of trials. There are in fact now 16 trials we know about. There's more going on in Denmark and Portugal. And there was one of the first ones came from Adelaide, from the service there. So again, it's something that's been developed mainly in Northern Europe, but is fairly widely represented. And again, if I give you a summary picture of the results for these studies, presented in the same sort of table as previously for stroke units, you can see that early supported discharge didn't influence the long-term survival. This is a group of people who had a good survival prognosis, but clearly it was a group who were at risk of deteriorating and requiring nursing home care, and the early supported discharge group seemed to avoid that outcome more frequently. And for every 100 who were managed in the early supported discharge trials, there were 5 seemed to avoid nursing home care. And as a result, at 6 months, 12 months after the stroke, there were about 5 extra independent survivors living at home. And I think this came as a bit of a surprise. It certainly came as a surprise to me, because I thought these services would be kind of equivalent to hospital-based rehab. but it did suggest there was some added value from having this multidisciplinary rehabilitation in your home setting, and then probably were able to provide a bit more rehab. And the other thing was that there, I didn't mean to, yeah, I don't have all the information here, but these services were essentially cost neutral. You spent a bit more on community-based rehab, you spent a bit less on hospital-based, and they kind of balance each other out. And what's tended to happen in the UK is they're seen as a way of sort of trying to move the system a bit better, get people moving through the system a bit better. The final two examples I'd like to mention are sort of later rehab interventions. Now, I've got to say, in terms of researching these, it gets more difficult further down the patient pathway you go. The services get more and more diverse and individual. But there are kind of two categories of approaches that we've lumped together just to explore the potential impact. And these are probably appropriate for about 50% of stroke patients who've got through the acute illness and are back home and living in a home setting. And just to explain what I mean by these terms, the therapy-based rehab trials have all involved physio or OT intervening in somebody's home to try and improve their activity. So focusing on altering things so that they are less disabled in their home setting. But bearing in mind, this is a group of people who've been through the whole healthcare system and are now sort of further down the line. In contrast to stroke liaison worker services, this has particularly been popular in the UK, which is having a nursing or social work professional visiting people at home, providing information and advice, and liaising with services to try and support them at home. And by and large, these were aimed at increasing participation, allowing people to lead a more normal life in their home setting. And both of these approaches have had an impact. In the therapy-based rehab service, there was a significant result in that people who got input like this were less likely to deteriorate in their ADL score. So they're more likely to maintain their ADL score at home. And there were specific benefits. It was very much a story of what you focus on is where you get the benefit. So for instance, there are a couple of OT trials focusing on extended ADL, and people tended to improve on those components of activity. And there was one trial published a few years ago which developed a program of outdoor mobility, helping people improve their outdoor mobility, and people who received that service did improve on their outdoor mobility score. In terms of the stroke liaison workers, there seemed to be a subgroup of patients might benefit, although that was not absolutely certain. And there were a number of aspects of satisfaction that patients and their carers reported greater satisfaction with this type of service. So there were